and diversion interventions. And for those who don't know me, my name is Christina Clark, and I'm a quality improvement and change management consultant working with CCMI. CCMI stands for the Center for Collaboration, Motivation, and Innovation, and that's a non-profit dedicated to creating partnerships that help improve health and well-being. So I've worked as an improvement advisor for about 10 years now. I've planned and delivered a number of collaborative improvement projects to support care in a number of different settings, from primary care to acute care, working with government to direct frontline service providers, and across a number of topics: chronic disease models, sepsis care, intra-patient hospital transfers, HIV, so quite a few different topics that I've worked with. I've also spent a lot of time delivering quality improvement training and am familiar with each of your projects, which is fantastic. And I'm really excited to get to know each of you a little bit better and to hear about your work as it progresses over time. So my goal is to bring you some improvement theory, but to ground it with practical tools that you can apply to your projects. And I'm really hopeful that we'll be able to share lots of concrete examples as we're going through this work. I'm going to be calling on each of you to bring some examples, bring some comments, challenges that you're experiencing as we work through some of these theories, but also apply it directly to these improvement projects. So just a note that each of these sessions, so we've got the 4 sessions starting today and the last one on June 18th, so each Tuesday at 8 a.m. Each of the sessions will build on each other and will be important for the next session. Totally understand that there's things that pull us away, so we are recording each of the sessions and you'll be able to watch them if you aren't able to attend in person for the session itself. In between each of the sessions, there's going to be a little bit of pre-reading to get ready for the subsequent session, and possibly a small assignment. And we do this because we know that as learners, we're only really able to absorb about 10% of what we learn. And if we're able to apply it immediately following when we hear it, that increases substantially. So I don't want to burden anyone, but there's going to be just a couple of small activities to be able to apply the content directly after. Probably everyone is pretty familiar with the Zoom technology we're using, but just a quick overview, and I'll only do this once. On the bottom of your screen, your window, Zoom window, you'll see the mute or unmute. If you are not speaking, actively speaking, I'll just ask that you mute your line so we don't have background noise. Encourage everyone to share their video and for us to see your lovely faces every morning. It really helps to create a bit more of an engaging learning environment. And then finally, the chat function allows you to chat with fellow participants, so feel free to use that throughout the session. Add questions, comments. We'll do a roll call at the beginning of each session to see who's with you. So feel free to use that. And then just a reminder that we are going to be recording these sessions, and John will make those available after the session itself. So we've already started with a little bit of introduction, so that's fantastic. If you've just joined, please use the chat box to add your name, your role, your organization, and if there's anyone else in the room with you. Thinking specifically about today's learning objectives, we have a couple. So the first is that we really hope that after the session, you'll be able to distinguish between quality improvement and other quality management approaches. And secondly, we hope that you'll be able to describe the model for improvement and its 3 key questions that drive improvement. Now, I just want to pause. Those are the learning sessions or learning objectives we set, but probably there's something that drew you to this session. There's a reason why you're here. Maybe you're told to be here. But I just wanted to get to know a little bit more about what you're hoping to learn from this and from all of the future sessions. So feel free to unmute yourself or to just add some comments into the chat box. So what are you hoping to learn from these sessions?
This is Kelly at QI Medical Center. I think I don't necessarily have any expectation of what to learn or get out of it. I'm just trying to take in all information possible to be able to turn it around and use it at our facility.
Great, that sounds good. And I think this is from Vicky, brand new to QI, so hoping to learn everything. Everything, I hope you, I hope you learned something, but maybe not everything. And from Rhonda, we want to develop collaboration with our partners and learn from others on how they're making improvements. Thanks, Rhonda. That's also one of my hopes. So I'm going to be leaning on everyone to, use the unmute button and share some of the things that you're doing, share some of the innovations you're working on and challenges, and hopefully we can develop a really nice collaborative community where we're able to share, and that will really advance the progress of our improvement over time. Anyone else? What are you hoping to learn from these sessions?
This is Ray Eichmeyer from Lake Chelan Community Hospital and EMS. I just kind of hope that I'm on the right track, so I'm hoping I'll learn that confirmation. How about that?
Okay, sounds good. And for you, Ray, and for anyone else, I'm available throughout the 4-week period too. So if you have specific questions, if the content didn't address it directly, and you want to sort of validate what your ideas are or your approach, don't hesitate to reach out to me, and my email will be at the end of the slide deck. Anyone else? Okay, I'm just jotting some of these notes down so we make sure we hit on them before the end of the 4 sessions. Okay, let's get started. So let's see. What I really just wanted to start with was a little bit of context and level setting. In the quality world, you might be familiar that there's lots of flavors of the month. And sometimes we see this when leadership changes and there's a new quality model introduced. Sometimes it's when the importance of quality work is emphasized or de-emphasized depending on the manager or the director. But at its core, quality improvement really is a philosophy and it's a discipline. And I think it helps to start with a little bit of context to recognize what is quality improvement and how is it different from other ways we might talk about quality in organizations. So just to start from very early days, and not to do too much of a history lesson, but the practice of healthcare really started out as a craft or a guild, almost like artists of the day, where trainees would work directly with a mentor and study from archives. And in those early days, healthcare quality improvement arose from really a series of seemingly unrelated incidents and developments. So for example, in the 1840s, Dr. Semmelweis discovered that hand washing cleanliness led to disease reduction in Vienna's maternity wards. Inspired by this, in the middle of the 1850s, Florence Nightingale used observation and meticulous record keeping to test out a number of improvements that reduced mortality rate among British troops from 43% to 2%. And some of the improvements that she introduced and tested over time were disinfection of latrines, reducing overcrowding in hospitals, removing horses that were stabled in the hospitals. But while there were some pretty significant advances and innovations over this time, there weren't really any structured or organized approaches for carrying out quality improvement. And as the 20th century emerged, the general public was starting to become a little more aware and a little more savvy of errors that were occurring in hospitals and quality gaps that were occurring. avoidable mortality, infection rates, and the like. And so healthcare practitioners seeking to restore confidence and maintain some autonomy of the practice really began to propose quality regulations and standards. And those were standards that they said hospitals should maintain. And so during those early days, the focus of quality was really on assuring it against a standard, what looks a lot like audit and inspection. But as we moved into the 50s, healthcare starts to get a little more sophisticated, and they start looking at other industries. And in particular, they were looking a lot at manufacturing for some innovations in quality. The Toyota production system that introduced the lean model for improvement, which focused on ensuring value for customers and driving out waste like weighting or defects. Six Sigma, another quality framework, was developed at Motorola, which focused on eliminating defects. And then in the middle of the 1900s, a fellow by the name of Dr. W. Edwards Deming, he was a key thinker in modern quality management practices, began to consolidate a number of theories to produce this sort of modern paradigm for thinking about quality management in organizations. And what he did was he started to aggregate different science, different theories around a few common themes. And he brought together statistical theories developed by Walter Shewhart, sampling methods, as well as studies on human psychology and behavior and a few other things. And what that led to was the development of what he called the theory of profound knowledge. So Dr. Deming said that you have to first understand organizations as systems. When we make a change in one area of the system, it can have a ripple effect in another area. So when we want to make changes or improvements, it's not just about training people, right? He said that about 98% of your problems in your systems are due to the design of those systems and not the people within it. So that we focus on design of the systems, we can get greater leverage at changing outcomes and changing behaviors. The second piece that he talked about was that if you understand systems, you can measure variation within it. He said you manage what you measure. And if you measure that work, you'll find there are two kinds of variation. So there's variation that he noted was due to the design of the system and how all the inputs come together to create an output, and he called that common cause variation. The other type of variation he pointed out is called special cause variation. And that's the sort of stuff happens variation. Sometimes we more often are familiar with calling this sort of an outlier or an outlier data. It's something that's not common or inherent to the system, like it could be increased wait times in the emergency department because of a major multiple trauma incident. It could be a critical incident or error, a complaint from a board member. And Deming said that management tends to focus a lot of time and energy on these special cause variations, which can be unpredictable and unavoidable. And so he advocated that the greatest improvements can be made when we look at the fundamental systems that produce the common cause variation and focus our efforts not on the special cause, but on the common cause. The next part of the theory of profound knowledge focuses on how people learn. So if we're going to make changes to variation, we have to understand how people learn. And he connected this to epistemology, the study of how we create knowledge, how we distinguish between opinion and what is justified belief. So theory testing, like the scientific model or hypothesis testing, it's built into the models that we use in improvement. It's built into PDSA cycles, which we'll come back to and explore in greater detail. And lastly, we have to understand that we can provide tools and the ability to act, but we also need to understand how people change. So the last piece of the theory of profound knowledge is psychology. How do people respond to change? And how can we make change easy through change management? And we'll talk a little bit more about change management and psychology. It's woven a little bit throughout, but we'll come back to that in session 3 and 4. So all this to say that quality improvement is more than quality assurance, which Deming referred to as reliance on inspection for quality. So quality improvement is really a systemic and it's a formal approach to making measurable improvements in systems. There's quite a few models that exist. I mentioned Lean, I mentioned Six Sigma, but it's important to note that quality improvement is really more than just that reliance on inspection and audit, and that there's a disciplined approach that we can take for quality improvement. So I just want to pause there and ask you, where do you see quality improvement in your organization? What examples do you see of quality improvement? Or maybe of audit and inspection?
This is Ray from Lake Cheyenne Community Hospital and EMS. We have key performance indicators for basically goal-oriented care, and so we track those as quality assurance to make sure that we're meeting the best for the patient.
Mm-hmm. That's great. So that's taking a look at your variation. And does your organization have a formal or planned way to act on what it sees from those KPIs or key performance indicators?
Yeah, we try to identify what is the cause if they are outliers, or if we have low KPI performance. So what is the cause behind it?
Great. So maybe like a root cause analysis or some other investigation. What about others? Where do you see this in your organization?
This is Kelly with Cooley Medical Center. We do PDSAs for most things, that we're going to look into or change.
Great. So I'll be coming to you, Kelly, when we start talking more about PDSAs next session.
Oh, okay. Well, hopefully our quality improvement director will be able to come. He's not here today, so I know that we do PDSAs, but I can't give a whole lot of other information since I'm not usually involved in that stuff.
Okay, no worries, Kelly. Anyone else? Where do you see quality improvement in your organization? And sorry, I should stop. For those who don't know, PDSA is an acronym that stands for Plan, Do, Study, Act. And it's an iterative learning and testing cycle. And we're going to talk a lot about that in the next session.
Christina, this is Rhonda, and I just wanted to say at North Valley Hospital, we do have PDSA built into our quality improvement program. Like all of our departments have dashboards, and if they do not meet the standard for 2 quarters or 2 months, depending on how it's set up, then we do a PDSA to see how we can make that improvement within our system.
Great. So you're looking at some measures, and when you're not achieving the performance goals that you've set, then you start testing some changes to try and get back to where you want to be. Is that sort of what I'm hearing?
Yes, that's correct. And then if we do have special cause variations, and when we have that, we will do an RCA. Mm-hmm. And what it boils down to is it's actually a repair of our common cause. We find out generally that that's the baseline is that's a common cause, that error in our system that we need to fix. It never has to do with people.
That's great. Thanks, Rhonda. So Rhonda just mentioned an RCA, and that's a root cause analysis. So when they see an example of a special cause variation, so something that's producing some strange data, they'll take a learning approach using a root cause analysis. What caused this, and what can we change as a result of it? And it sounds like most of the time they're finding that it is connected to something fundamentally in the system, and changing processes within the system. Okay, thanks. So lots of examples of different quality processes being used in your organizations, and hopefully that overview wasn't boring, but also hopefully it helps to sort of see that quality improvement isn't just a single model. And when we distinguish it from other approaches to quality management, what I'm really hoping to impart is that quality is more than audit and inspection. And it involves things like change management and psychology, looking at variation, and using a planned and structured approach to deliver on some of those improvements. And that's what we're going to introduce today. I've already noted that there are quite a few frameworks, quite a few models out there, and your organization might use one of those models and frameworks, and that's fantastic. So Lean is a really common one. Six Sigma sometimes finds application in healthcare. Really, I just want to say that it doesn't matter which model you're using, as long as you're using a formal and organized approach to carrying out improvement work. What really matters is consistency of use of that model, and the fact that you're using it in a purposeful, organized way, and that everyone understands the model and everyone's using the model. So today we're going to teach the model for improvement, and this was a really common model that's used in healthcare. It works really well with any of the other models like Lean or Six Sigma. We teach this one because it's simple, the language, it's simple in concept. It's not a simplistic model, there's complexities to it, but it's one that's so universal in healthcare that it's a great one to learn, and it's good for smaller or larger systems, so it scales really well. And this will probably be familiar to a few of you who've worked on your improvement charter because it forms the foundation of that improvement charter. So here is on your screen the model for improvement. It was developed by the Associates for Process Improvement based on the work of a number of pioneering and leading thinkers in the disciplines of management theory, psychology, statistics, and a number of other disciplines. So Deming, the theory of profound knowledge, really underpins this model. It's simple, it's pretty practical, and it just uses 3 questions and a process for testing and learning that we've heard a couple times, PDSA cycles. So let's take a look, let's unpack it. Where can you find more on this is in this book, and I really encourage for all of you to get your organizations to go out and purchase a copy of this book, The Improvement Guide. It covers the model for improvement in depth, the foundational theories, but it also uses a lot of practical examples, a lot of case studies, so you can see how data is used, how organizations might apply this model with some great examples. So now we unpack. So here, the model for improvement, question 1. So again, there's 3 questions in the PDSA cycle. Question 1 is, what are we trying to accomplish? And the principle behind this question is that all improvement starts with an aim. We set an aim at the outset because an aim provides a goal, direction for where we want to go, and alignment with the goals and priorities of our organization. And everyone has already set an aim in their improvement charter, which is fantastic, and they're all really good aims. But just to review, for those who maybe weren't so involved in their improvement charter, making a great aim statement, there's a great acronym, or mnemonic, I suppose it is, that we can use, and that is SMART. So when we set up an aim, we want it to be specific, measurable, actionable, realistic, and time-bound. So when we're looking at developing our aim statement, we want to make sure we're including each of these aspects into the aim. And when I'm done going through some of the aspects of the model for improvement, Rhonda has agreed to share a little bit of their aim statement and hit on some of these points. Question 2 from the model for improvement is, how will we know that a change is an improvement? And this question recognizes that while all improvement requires change, not every change will lead to an improvement. And so key is that measurement tells us whether the changes we're making are actually leading to improvement. So how does measurement help us in improvement? You probably have a lot of ideas of your own, but here's a couple that we've put together. The first is to understand if the changes we're introducing are contributing to the aims that we set. So fundamentally, when it comes to measurement and improvement, we want to measure over time to be able to tell temporally if the changes we're introducing are leading to any changes or any changes in the measures. So every time we test a change or we choose a change that we're going to test, we're basically making a prediction. The prediction is that the change will result in some improved process and outcome. So for example, if we predict better access to primary care will reduce ED utilization, we could predict that follow-up with a primary provider after hospitalization will reduce readmission. We might predict that addressing the social determinants of health will reduce repeat ED utilization. And so there we're making a prediction that those changes will lead to the aims that we've set. And so key to knowing if it's true is measurement. Another reason we might measure is to understand where are we currently at towards those aims. So what is our progress and what is our performance? We might want to compare performance with similar sites for learning. So a really great strategy when we're doing collaborative improvement is a number of sites are collecting similar measures. And we're able to take a look through sharing, take a look at each other's performance and share with each other, you know, what innovations or what change ideas did you use that are giving you such great results? Or we're stable. I wonder what it is that's contributing to that stability and how might we maybe overcome the stability by seeking improvements from other sites. Measurement's also really helpful to identify unexpected outcomes. And so a really classic example of an unexpected outcome is if we're attempting to reduce in-hospital length of stay, but we don't put in place all of the safeguards maybe, or we haven't predicted how the changes we're introducing are impacting other parts of the system. And so as we're measuring reduction in length of stay, which is our aim, we're also seeing an increase in 30-day readmission. So that would be an example of an unexpected outcome. And then, of course, to know when we've reached our aims is why we would measure. I just want to pause and note that there's a few principles of measurement for quality improvement. While measurement is really important for improvement, I just want to make the point that measurement is not the purpose of improvement. And with that in mind, time and effort spent measuring is viewed in the context of trade-offs. So time spent gathering and processing measurement is time we're not spending delivering care or testing a new way to deliver care. However, measurement is still the way we'll be able to understand if the changes are leading to improvement. And so because of that, because we acknowledge there's a trade-off there, we need it, it's essential, but it's not the purpose of what we're doing. We use a couple principles. So we keep in mind that the purpose of measurement for improvement is learning and improvement first and foremost. Second, that the data we collect should be useful. It's not perfect. So this isn't a research project. We want the data to help us to learn and to improve it. Third is that we want just enough, good enough data. Again, going back to a research project, this isn't that. We don't need to eliminate bias. We need to know about bias. We don't need perfect data. And then we want to make sure our measures are aligned with our aims.
I have a question. This is Ray Ackmeyer.
Go ahead.
Hey, even though that in tracking data and looking at data is not a change for the people, but have you ever heard of the Hawthorne effect? Just because you're looking at it, it creates change.
Mm-hmm. Yeah. So what do you think about that in the context of the principles of measurement for improvement?
I think it just contributes to the psychological of the it actually improves things without even doing a single change, just by measuring it. When
Mm-hmm.
people know that we're looking at it, then there's actual changes that occurs, like better quality, more people think about it more. You don't have to actually change anything, and actually it changes by itself.
Yeah. So do you want to explain for others what the Hawthorne effect is, just in case others don't know? You kind of did, but.
The Hawthorne effect really is telling the staff, like, hey, we're going to measure how many times you gave aspirin to a chest pain patient, and not changing the procedure, not changing the location of the aspirin, not changing the protocol, not doing anything different, not even training them, just telling them, hey, we're going to measure this, and all of a sudden aspirin use and during treatment will improve all by itself.
Thanks, Ray. Yeah, so that's a really great comment, and it's something that comes up, and something that was actually included in the list of the psychology evidence that formed the theory of profound knowledge. So the Hawthorne effect, just like Ray described, is basically when you're being watched, you're more likely to change your behavior. So in the example of giving aspirin to a chest pain patient, if you're being told, we're going to measure this, you might have it at the front of your mind. The problem is that it's not a change in the system itself. It's reliant on memory, and people are changing their behavior because they know they're being watched. When it comes to improvement, an effect like this in our measurement is an example of say, a bias. So we might know that as we're focusing our improvement efforts on a change, that we might have the Hawthorne effect present. And that's okay. That's, if you see some changes in your data because of that, that's okay. The interesting thing about it is it's usually not sustainable. So if you're looking at data over time, you start an improvement project at the start of the year, and you have an active improvement phase for, say, 6 months. You might see some improvements in your data and think, we're doing great now. But typically, if you continue to collect the data, if it's really just the Hawthorne effect, it's probably not going to be sustained because people will realize we're not really actively paying attention to this. I've heard a few different thoughts about this. Some people think, you can use an improvement, you can use the Hawthorne effect to your advantage. Just making sure that you're collecting the data and looking at variation. So is that an example of special cause variation where behavior is changing just because you're watching it? You also want to make sure that you're looking at the common cause variation. So which systems have you fundamentally changed to make sure we don't just rely on memory or training? We're making it easier for people to do the right thing. Anyone else, any thoughts about the Hawthorne effect? Okay. So then this kind of speaks a little bit more to improvement data and what we're looking for when we talk about improvement data not being perfect, I should say. So this is a great table that has been adapted from an article by Solberg and all. It's a little old, but it's still super relevant. It's from '97, called The Three Faces of Performance Measurement. And what these authors did was they identified 3 types of performance measurement. So improvement data, accountability data, and research data. So improvement data is, the purpose would be to improve systems and processes and to learn. When it comes to accountability, that's sort of your comparison, your choice, usually a government type of report, typically to spur change. It could be sort of an audit report as well. But research, again, is different, and the purpose of research data is to create new knowledge. When it comes to bias in each of these types of performance measurement, improvement accepts consistent bias. So we know that potentially the Hawthorne effect is happening, and that's okay as long as we know about it, because it helps us interpret our improvement, it helps us learn. When it comes to accountability, accountability data, usually we want to measure and we want to adjust to reduce our bias. And when it comes to research, we design research studies to eliminate bias completely. When it comes to sample size for each of these three types of measurement, improvement wants just enough data, small sequential samples. Accountability typically takes about all data that's relevant, and research will take another step, which is just in case data. So we might need to characterize this further. We want as much data as we can, and we'll track some stuff just in case. To determine if a change is an improvement, improvement, we use run charts or control charts, and we'll talk more about those, especially in the third session. With accountability, there's typically not a change focus. There's no determination of whether a change was an improvement. But in research, there are some traditional hypothesis statistical tests that we often use, and p-values is one that people are really familiar with. And then finally, confidentiality of data. So when it comes to improvement, data is used only for those involved in improvement, and it's aggregate data. So it's stripped of patient identifiers. With accountability, data is available for public consumption and review, and in research subject identities are protected. So hopefully that gives us a little bit of a sense of the different types of measurement. My key point is that when it comes to improvement, we're not looking for perfection in our measurement. We're looking for just enough, good enough data to tell us if the changes we're introducing are in fact leading to our aims or improvements. Is that helpful? Okay, well, just let me know if there's any questions about that in the chat box. Hopefully that helps clear things up a little bit. Yeah, go ahead.
I have a quick reflection. I just wonder if the TCDI partners on the phone, if this resonates or not, but I think what we were trying to do with that measurement guide for everyone is, it seems like the data that we're asking partners to report kind of straddles a little bit between the improvement or accountability, or it actually probably feels like an accountability measurement because they're sending measures back to the ACH, but we really tried to clarify that the purpose of the measurement is for improvement. That's what we're trying to incentivize. So I wonder if some people just felt like a little bit of a tension between those two buckets. That's kind of a question for the TCDI partners.
Caroline, this is Tracy, and I honestly did not feel like it was an accountability thing. I felt, you know, you and John have been wonderful in you know, helping us through, and I view it as an improvement. You know, not only showing you that we're doing an improvement here, but also showing it to the people that are, you know, entrenched in each measure, and showing, hey, this is the work that you're doing, and look at how wonderful you guys are doing. So that's the way I've looked at it. So
that's great.
Any other reflections?
This is Ray. I also think that I didn't think it was accountability. I felt like it was just quality. Are we making a change?
Can I say, this is John? If someone feels like they're just tracking for accountability, and you don't feel comfortable speaking up today, please reach out to us, because we do want to make sure that whatever you're tracking, you feel like you have a true quality improvement purpose out of it. And so we are comfortable working with you guys to make those adjustments, because all this is really to improve work at your guys' organizations and share that across to each other. And it's less, we'll deal on the back end what we need to deal with on the reporting.
And we're going to come back to measurement and making it work for us and making it valuable next session too. So if you have other reflections by that time, we can also talk about them then. So just moving forward with the model for improvement, measurement is necessary, but again, it's not enough to produce change. So the last question in the model for improvement is, what changes can we make that will result in improvement? And this is really about the changes and the ideas that we can test in pursuit of our aims. These are the changes we're going to make in our systems. And there's lots of places that you can probably think about that change ideas can come from. We've listed just a few ideas here from the improvement guide. So logically thinking about your system, learning from clients, staff, experts, other organizations, evidence. And then the last bullet here talks about change concepts. In the book, The Improvement Guide, on page 132, there's 72, I think, different change concepts that can be used to find specific concrete ideas that you can test. But when it comes to this specific work, I just wanted to cue John up because lots of work has been done to start to consolidate some of those change ideas already. John, you want to talk a little bit about that?
Yeah, so, as a region, we chose a couple specific topics that we wanted to focus on with the goal of shared learning and education across different partners. And so you can see on the screen, we all went and we got trained specifically on the transitional care management model as Confluence Health had adopted it and made their changes. But I know across the different partners, knowing that there's different sizes and you guys configure your departments differently, you've all adapted how you specifically do the transitional care management model to fit for your region. So I know some partners are doing both follow-up out of the ED and inpatient together under one staff. Some may do it separately, and then some may also turf it to the primary care clinic of your organization as well. And so those are, starting to talk about how you develop the changes and how you start developing those processes for follow-up are very important. Same thing with the emergency department diversion and follow-up out of the emergency department and educating patients. In ED diversion, we focused on educating patients on the appropriate utilization of care, follow-up, and then also better utilizing the collective medical platform to, again, do our part in ensuring that patients that get discharged out of the emergency department, get connected with primary care, get the information they needed and understand what they need to do so that they don't get readmitted or that they don't end up having another ED use. Ray, we are also doing a community paramedicine model across the region with 8 or 9 EMS agencies. And Ray, actually, I might ask you to give a quick blurb on what you're doing, because Ray has actually also merged community paramedicine with some of his transition and diversion work. And this is just an untapped resource that we don't all know about, is the EMS partners in our community, and they have a lot of potential to grow and be an integral part of prevention in our medical community, not just transport of crisis and acute care patients. Ray, do you mind sharing 1 or 2 tidbits on that?
Sure. What do you have in mind for me to share?
A little bit of how, why don't you share how you are utilizing, why don't you share the component of your EMS proposal with the high utilizers?
For the hyper utilizers, is what we're doing is we can measure how many times you've been in the ED 3 times in the last 12 months and 5 times in the last 12 months. And what we're doing is we're going out and doing basically kind of like coordinated care like Healthy Homes does. And it's kind of like a combination of Healthy Homes, transition and diversion. and then hooking up with our primary care provider. So I get the full story from the primary care provider. I go out and do a site visit at their house to determine if there's some social determinants of health, which there always is, and then why they haven't, maybe are they not compliant with their care plan. How come they're not going to their PCP? If that's a problem, educating them why they should go to the PCP instead of the ED, because ED is usually a short-term fix and not a long-term. I mean, there's so, I could go on this forever, but I mean, that's kind of what we're doing. Is we're doing home visits, site visits, phone call follow-ups, discharge follow-ups. We're kind of taking multiple models and combined it into our resources that we can do, which is basically doing a little bit of everything. And I think in a rural area, you really have to do that. We do it already. All of you on this, you guys have multiple hats you do inside your hospitals or clinics, and that's what we have to do to move this in, for us anyway.
Yeah, so just Ray is a good example of, we have 3 main topics we're focusing on as a region around transitions, ED diversion, community paramedicine. And we know on those topics, everyone's going to be doing it slightly different. And so their change ideas are going to be specific to their organization, their region. And so Lake Chelan did they have a very robust community paramedicine model. And so they've been able to integrate that into both their TCM and ED projects. And that's the kind of sharing we'll hope to see, because I know a lot of partners have similarities across the region where they can learn from each other.
Thanks, John and Ray. So once we have all those change ideas, which many of them we do have, and it's just a matter of tailoring them to our own setting, the last part of the model for improvement is the PDSA cycle. And that's a structured approach to quickly be able to test, adapt, and implement changes over time. And we're going to talk a lot more about this in the next session. So I'm not going to cover what's in the PDSA cycle, but I do have a leave-in action where I'm going to ask you to think about a change that you want to test with the PDSA cycle. And all of this information will be in a handout that we'll send at the end of this particular session. So that was a really quick overview of the model for improvement. And what I'd like to do is ask Rhonda, who's graciously agreed to share a little bit about what's in her charter, so you can see, and many of you have already done your improvement charters as well, so all of this is really nicely contained within it, but I wanted to beef up some of the sharing. So I'm going to invite Rhonda to talk a little bit about her charter.
So the development of our charter was a team effort. We used the CNO, the COO, quality, charge master, and the manager of the emergency department. And I don't need to read what our aims are. You can see that. But transitional care basically is to decrease our readmission rate, and we are moving in the right direction. Sorry, I have a cold, y'all. I've been sick. So to reduce the 30-day unplanned readmission rate, and then for the emergency department, our interventions to improve post-discharge follow-up, and collaborate and implementation of our the ED system. Next slide. On our measures, you can see with our transitional care management calls to discharge inpatients, follow-up appointments, and readmission rates. And I want to speak a little bit about that, is because after we started the project, we encountered some issues where some unknowns. In other words, Confluence, when we did the training with the Confluence, we found out that Confluence Transitional Care was calling some of our patients that were specific to them. Well, our only physicians currently are Confluence physicians. So now I've been working with our local clinic to make sure that we're not duplicating calls. And I've been looking more at, they all have that follow-up appointment, but are they making it and attending that follow-up appointment? So that's something that has changed in our, because that's something that's more accountable and it's relevant versus where it would make a difference, not just do they have the appointment, but are they actually getting to it? And our readmission rates are decreasing. But I found out on Friday that there's another group of patients that Confluence calls, and they are in a special group, and one of this was a cardiac patient. And so they had called me to tell me, excuse me, from Wenatchee, that they, from their transitional care center, that they have called this patient and they had some questions for me about follow-up. And so we collaborated on this specific patient's care, which I thought was very interesting because I didn't know that they had a bundle, a group that were in a bundle that they managed their care as well. And then for the diversion interventions, you know, because the whole idea for the emergency department diversion is to use the emergency department as emergency department and decrease that, decrease, I hate to say abuse, but using it for your primary care. So one of the things we've done is increase the education for our local area. When we develop this folder, you can see this North Valley Hospital, it's a discharge folder, and on the front it has all of the telephone numbers for our local resources within the hospital and also our clinic. And we're not only using this for our ED patients, emergency department patients, but our inpatients as well. We also have implemented the inclusion of the ED system, EDI system, excuse me, I don't say it right, EDI system into our daily ED workflow. And our next hurdle is our follow-up appointments from the emergency department. So when those patients are seen in the emergency department is during the hours, you know, Monday through Friday, is scheduling their follow-up appointment with a primary care or coordinating them with primary care. And what's going to help that is our family health center is hired new physicians and increase in physicians at Confluence and possible, you know, rural health clinic here. So lot going on, but our numbers are showing and demonstrating improvement, and that's the overall goal.
Thanks so much, Rhonda. I'm sorry to cut it short. I didn't manage the time so well, and we've only got 2 minutes. I want to make sure everyone gets out on time. But is there, very quickly, any questions for Rhonda?
Rhonda, this is John. I just want to say that it's really impressive what you guys are doing, especially as a small rural hospital without a primary care clinic at this point. So it just shows what can be done when you put your mind to it.
Yeah, and I'm sure Rhonda will be calling on you to share more as you continue. So thanks so much.
Oh, thank you. It's with your help that we can do this.
Awesome. So just want to direct everyone's attention. The next session is on Tuesday, again, 8 to 9. I'll send out some pre-reading, a little bit of handouts there. And then what I'd like everyone to do is to think about a change that you would like to test using a PDSA cycle. And we'll come prepared to discuss that at the next session. So that'll be in a follow-up email as well. With just not even a minute left, I'm just going to bring up a poll. We really want to hear from you about how this went so that we can improve for the next session. And whenever you're done the poll, please feel free to drop off the call. So thanks so much for joining us. And we'll definitely build in more time next time for questions as well.